Morning, sir. Dr. Joseph, I am Dr. Srinivas Kumar. I am able to see you and hear you. Please, you have excellent panel here. Dr. Sushil Kodali, Dr. Ramesh Dagupati, Dr. Rahul, and Manutosh Panja. Please go ahead and present the case. We are able to see you and hear you, sir. Please.
Okay, excellent. Good morning from CMC Vellore. I'll present my team. This is Dr. Sujit Chako, my colleague. Where is Surya? Is a consultant with us. The anesthetics team with us, Dr. Kiribakaran, is all behind the gantry, Dr. Ben Babu, Dr. Balaji, and then we have our technical team led by Kezia. So without losing more time, they already lost 10 minutes, and this being a fairly complex case, that's a significant amount of time. So we've got just 50 minutes to show you an interesting case. So can we have the slides, please? So our patient for today, can you tell them we want the slides? Yeah. Can you see the case details there?
Yes, we can.
Auditorium?
Yes. We can see it.
Okay, so we have a 43-year-old male who's hypertensive. We had sudden onset of severe epigastric pain in 2014 and associated with syncope, and then he was diagnosed to have a type B aortic dissection which extended all the way to the right common iliac artery. And of the visceral vessels, the right renal artery came off the false lumen, and over time the right kidney has shrunken. But his creatinine is normal, 1.25. His LV is normal, his coronaries are normal. He came to us 2 years later, and we've been following him up for the last 1 year. He is asymptomatic. Next slide, please. So that's the 3D reconstruction of his aorta. You can see a type B dissection extending from the left subclavian onwards to the right common iliac. And the right kidney, you can see, is smaller than the left. It's opacifying less than the left. And this dissection starts right at the left subclavian. What you're seeing is the luminogram. So actually there is a thrombus-filled part of the dissection abutting onto the left subclavian. And you can see the three arch vessels are very close to each other. And you can also appreciate that the true lumen is really squashed in the image on the right by the false lumen. Next slide, please. So we've been following him up for a year, and you can see a subtle increase in that aortic knuckle shadow size. And next slide, please. The CT also shows that the next slide, please. The false lumen has now crossed 5 centimeters. It's 54 millimeters in the axial view. And next slide, please. And 56 in the coronal view, and you can also see some thrombus lining the false lumen. So there is a progressive growth of the false lumen, and it has crossed 5 centimeters. So given these two points, we feel that it's time to intervene in this patient, even though he remains asymptomatic. Next slide, please. So we have planned this intervention, and this is a 3D reconstruction that we have done using Radiant DICOM software, which is freely available on the net. And you can see that the ascending aorta measures 33 millimeters just before the innominate, and the distance from innominate to left carotid is 14, and left carotid to left subclavian is 16 millimeters. Next slide, please. So we are planning an endovascular repair with 2 endografts. Higher up we'll put a 34-200, lower down we'll put a 30-200. And we'll start from the ascending aorta and take it all the way to the celiac artery. And so since we're covering the arch vessels, we're going to have fenestrations for the 3 arch vessels. And we're using femoral percutaneous access. Actually we're using the right, not the left. And we've already deployed 3 ProGlide sutures in the right femoral artery at 10, 12 and 2 o'clock positions, and we'll tie it off at the end of the case. So there's no cut down anywhere. So we also got left femoral 6F, left femoral venous 6F, and both radials 6F. Access is already in place, and also a carotid wire through a 4F dilator. So there's no sheath in the left carotid artery. Next slide, please. So I'll just show you what we're trying to do. This is an example of a case we did last year, similar type B dissection extending down the aorta with a large false lumen. Next slide. And next slide. Yeah, this is what we plan to do. We'll cross the arch, go all the way down to the celiac artery, and the 3 fenestrations will be for the 3 arch vessels. And we'll put stents into the left carotid and left subclavian. The innominate we generally leave open the fenestration, but we can actually put a stent there if we want to. But since there is sealing beyond the left, beyond the innominate, we generally don't have to put in a stent there. If you have to put a stent, generally the innominate is a large vessel, short vessel, so a bulky stent has to go in there. So we try to avoid it if not required. Next slide. So this is the planning we did. This is a superior view of the aorta. You can see the 3 arch vessels, the ostia, and we measure the distance. It's the same thing in this view, 14 from innominate to left carotid, 16 from left carotid to left subclavian. And next slide. So we draw an imaginary 12 o'clock line through the 3 ostia, and so we can see the relationships of the 3 ostia to this imaginary 12 o'clock line, which is at the superior aspect of the arch. Next slide, please. So we make fenestrations using our fenestrators, circular and oval. We have both of them, and we line the fenestration with radiopaque wire and then resheath the device. Next slide. So this is what we have done. The bottom panel shows the graft that we are going to use today. We made 3 fenestrations, approximately the same location and distance as what the CT showed us. But you can see that the left subclavian fenestration had to go a little posterior because it had to avoid that strut. We don't like to make a fenestration over a strut. So to avoid the strut, we had to push that one a little back. We hope that that will not create too much of a problem canalizing it. But the innominate, you can see, is oval. So that is also done so that it fits into that valley in that strut, and the left carotid is circular. So the size is 12/8 oval for the innominate, 8 mm for the left carotid and left subclavian. Next slide, please. And then the other thing we do is to make 2 radiopaque markers line up with the 12 o'clock line. You can see them marked by the purple and yellow arrows. And these 2 markers are actually there on the graft. We just take it off from the top of the graft and line it up with this 12 o'clock line. And then we resheath, we make sure that this 8 marker is right on the surface of the graft under the transparent sheet. So the bottom panel, you can see the figure of 8s right on the surface. Next slide. So this is important because when it's on the surface, you can use this marker to get a rotational guide. You know, if the marker is right on top, you will see it as a slit. If you don't have it on the surface, if it falls into the folds of the graft, that marker is of no use in terms of rotation, as you see in the right panel. Next slide, please. So the important thing is to deploy the device in the plane of the arch. So the plane of the arch is, this is the plane where the stiff wire in the aorta, the ascending aortic and descending aortic part of it overlaps. So in today's case, we have determined the plane of the arch to be RAO 33. So we will work on the orthogonal view to this, which is 90 minus 33, which is LAO 57 degrees. So today's case will be done in LAO 57 degrees. So now we'll show you the angiogram, which we have done in LAO 57 in today's case. Can we have the fluoroscopy now? Slides off. Yeah, can we play the angio, arch angio? Yeah, so this is today's angiogram. We have placed a Lundquist wire in the ascending aorta from the right femoral artery, and we are doing an angiogram over this wire using a catheter called the Watt catheter from Cook. And we have 2 pigtail catheters coming from both the radial arteries, one in the innominate, one in the left subclavian, and we have a wire in the left carotid. So these 3 are marking the 3 arch vessels, and in this view we will deploy our graft and try to get our 3 fenestrations lined up to these 3 arch vessels. Before that, we are going to deploy the lower graft, which is ending at the level of the celiac, Next one. So this is the descending aortogram, and next one. And this is the abdominal aorta in LAO 57. So everything is in LAO 57. Freeze that. So you can see that the celiac artery is celiac artery, SMA, and the left renal are all from the true lumen, and we are in the true lumen with the catheter and wire. So that's very important to be sure about, because when you deploy the graft, you shouldn't accidentally be in the false lumen. So we're going to end at the celiac artery. So we've kept a catheter from the left femoral artery in the celiac artery as a marker, and yeah. So I think it's in the celiac artery with a coronary wire going up the artery. So this is a marker for us. So without too much ado, I think we'll work on with the case. But any comments from the panel? I've spoken a lot, but it is a fairly involved case in terms of technique.
Right, Dr. Joseph, this is a very clear explanation of what you're planning, and I think this is very important, and how to plan your case. I think it's very nice to show us all the steps that you have done, including CT and creating the fenestrations, and a wonderful job. Sushil, any comments?
No, it's just your decision to go forward, even though it's asymptomatic, is based on the size of the thoracic aorta?
That's right. That's right. 2 points. One is over a span of a year, we have seen a subtle increase in the size of the false lumen, and the size of the false lumen has now crossed 5 centimeters. False lumen, that is. If you add the false and the true, in some places it may actually be more than 6. So the total aortic diameter is probably more than that.
And is there anything in terms of, I don't do endovascular, these type of procedures, but in terms of the right renal coming off the false lumen, are there any specific concerns? And then also in terms of spinal ischemia and concerns about, for spinal injury, how do you manage, and what are you doing?
Correct. That's right. Great questions. So the 2 things we do to reduce spinal ischemia. One is to keep the mean arterial pressure up. So my anesthetic colleagues have kept the mean arterial pressure at 92 currently, and I always want it above 80. That's one very important thing. The second is that we always spare the left subclavian artery, and through that the left vertebral and the IMA, both of which are sources of blood supply to the spinal cord. So these are 2 things we do, and then at any stage after the procedure, if we find he's developing a paraparesis or a paraplegia, we put in a spinal drain at that time. But we don't do it electively before the case. He's only on aspirin as antiplatelet, so it should not be too difficult to put in a spinal drain without getting a bloody tap.
Wonderful. Yeah, I know some people routinely put it in up front.
Just for
that's right.
benefit,
That's right. We don't generally do that. And all right. So I think I'm going to now proceed. I'm going to deploy the lower graft, and I'm bringing in the. I've also got a pacing lead in the right ventricle for the deployment of the arch endograft. But right now we're going to work on the low. No. Show me the device. So this is a Valiant Captivia holding wire 3200 device. It's going up from the right femoral artery, and we are going to deploy it with its lower end at the level of the celiac artery. So I'm taking it up. Show higher up, please.
Is this a
so I'm
sheathless
going
system?
up the aorta here on. Beg your pardon?
Is this a sheathless system? How big is this device entering the artery?
Yeah, this device is 22 French. If you can focus here, there is no sheath. You can show here, camera here.
Camera can focus here.
Okay, by the time you get to it, anyhow, there is no sheath.
Okay.
It is just a device which has got its own sheath, so the endograft is within that. So we are going up, and I'm focusing more on the celiac artery at the lower end of the graph. Now go to LAO. LAO 53, take the camera back in case it hits. LAO 57. So you can see that I've got my catheter there at in the celiac artery. So that's a handy marker for me, and I'm going to deploy a little higher up. Show the top of the graph, please.
I don't
Can
know
you
how
push
this
the wire in? It's coming back.
I don't know how this graph deploys. Does it tend to move forward as you deploy, or is it pretty stable?
It's pretty stable. So I'm beginning the deployment. You can see the top of the graft opening, but I'm going to now focus on the lower end because that is what is important for us right now. Can you just test through the sheet just to be sure where it is? Test.
George, Dr. Panja
Yeah,
here.
so the catheter slipped down a little bit.
The proximal lane
so
just
I'll
distal
keep it
to the
there.
left subclavian.
Test again. Yeah, so we are all right now. It's above the celiac. So I'm doing the slow release, which involves rotating this purple blue handle towards me. It's a fairly slow process, but there you can see it coming down. The graft is deploying. One more test there, just to be sure that I'm fine. Yeah, so I seem to be okay as far as the celiac goes, and oh, okay, test again. Yeah, I think we're okay. Yeah, show the top, please. Yeah, so now we're going to release the top cap. Yeah, so we've released the top cap. Now we'll recapture the nose cone, and now we'll take the delivery system out. And before I take it out, we want the next device ready. So we've got the fenestrated device ready to go.
Can I ask a
we'll
quick
just do
question
an
here?
exchange. We'll take this one out and put the, yes, please.
So if you hadn't liked
Go
the
ahead.
position before you released the nose cone, could you re-advance it at that point, or no? After you had fully unscrewed it?
No,
No.
no.
You're committed.
Yeah, so you're committed
Yeah,
at that point.
the only stage at which you can move is before you release the nose, the free flow segment, and maybe you could have deployed the first two covered stent segments.
I see.
Till then you can do some movement, but after that it's difficult.
Okay.
All right, so now I'm going in with the second device. Now we don't need this celiac catheter anymore, so I'm going to take the celiac catheter out and use that as for pressure. Okay, all right, leave it, it's all right. So we have three pressures going right now. I'm seeing only one there. Where is this one? Okay, the carotid is not on, so I'm going to switch on the carotid pressure. Can you stop the flush and put? So I'm going to have three pressures. One is through each pigtail. So that's going to tell me the left subclavian and the innominate pressure. And one is through the 4F dilator that I have in the carotid artery. So that will give me the carotid pressure. So why I need these three pressures is when I deploy the delivery system, the graft, and align the fenestrations, it's important to be sure that the fenestrations immediately flow. So the pressures will tell me whether I've got flow or not. Okay, so yeah, so we've got all three pressures going. On the screen here, I've got the two, the left carotid and the left subclavian pressure, and the anesthetist has the innominate pressure. All right, so now we're going up, so the device is coming in. This is another 2 French bigger. This is a 34 French system. Now, I'd like you to look at the markers that we have. You can see that the marker, radiopaque markers, I'm rotating it to the external, to the right side of the screen. And you can see behind them the fenestrations. So, can you see both the markers?
Yes, we can see that.
Very nicely.
In the device, they are both like vertical slits or vertical lines, black lines. They are actually figures of 8, but because I'm seeing them end on, they're looking like vertical lines, and I'm in the LAO 57 view. So that tells me that my 12 o'clock line is oriented laterally in LAO 57. Okay, I'm going up. So I'm slowly going through this graft. Now this graft hasn't expanded all that much because the true lumen is, just hold it there. The true lumen is quite small. We may have, no, don't move till I tell you. So you can see that, those 2 markers are still like vertical lines. So now I'm going over the arch into the ascending aorta. So now these 2 markers will move from lateral to superior. Show the arch, please. Right, so here I go. I'm keeping the, don't move the table. So you can see that those 2 markers are superior now. There is a little rotation. One of the markers is become a little 8-ish. So I'm going to readjust that. Yeah. All right, so it's back to like a slit. Okay, so you can see that those 2 markers are still like lines, not figures of 8. Okay, so now we'll look at the fenestrations. You can see between the 2 markers we have the 3 fenestrations. Show a little higher up. Yeah. So the innominate fenestration is been under the innominate, the left carotid is correct.
Subclavian is also okay.
Subclavian is also okay, yeah. Yeah, the left carotid is between that bone. The wire is moved a little bit. Okay, I think I'm reasonably happy with my fenestration position. Pardon?
You want to check the carotid with the contrast? Or?
Yeah, maybe we can just shoot through this, so it'll be more convenient. Just remember to put the pressure back on. Okay, just shoot. Okay, see the left subclavian fenestration is moved a little ahead, no? Or is it? Oh, it's under, it's behind, okay. So the left carotid needs to go in a bit more, no?
Slightly more. Yeah, the whole thing can go in there.
That's more. Where is the?
In the middle, you can see the subclavian fenestration.
It appears you might have to push it in a little bit, right?
No, I think the left subclavian has gone ahead too much, no?
It's under it.
Can we just look at our graph picture again? I just want to bring up that slide. Tell them I want to see the slide of the graft. See the distance between the left subclavian fenestration to that marker. Just ask them to show the slide, please. There is one there? Okay. All right. Then I think we are okay. But I'm just double confirming. It is important to be sure that the fenestrations are lined up with the target vessels.
George,
So
what is the exact
I'm just
entry
taking
point
an
of
extra minute
dissection?
to
George, what is the exact entry point of the dissection?
Actually, there are multiple entry points, and there is one a little beyond the left subclavian. but the dissection extends a little backwards from the entry point and reaches the left subclavian. So there is a thin flap starting right from the left subclavian, although the entry point is further down. But you know that you can't rely on that flap to land your graft and get a and not tear it. See, if you just look at entry point and just start the graft just above that, there may be a retrograde part of the dissection, and the flap there may give way, and then you will get a new entry point. So you need to start in normal vessel where there is no dissection at all. So I don't worry too much about where the entry point is. I worry more about till where is the aorta dissected, am I upstream to that. So
you can define the type of
yeah,
dissection.
can you, it's not coming. Yeah, there it is. See, there is no gap. Just zoom the graph, please. Zoom the slide. Yes, so see, there is actually is it there? Okay, I think we are okay, and there is also the same distance from there to the innominate, which we can see well. Okay, so we are. I think we are okay. I've just double confirmed that my location is fine. I'm just looking at it again. Yeah.
Do you do
I
the
think
angio
it's
through
okay,
the
no?
innominate or no?
Okay. Beg your pardon?
Do you test in the innominate to confirm that it lines
Okay,
up?
so I'm. You want to inject in the innominate? Can
No.
you just inject a little contrast into that?
No, I mean, you don't have to if you're
Yeah.
comfortable. We're just asking
What your
whether
technique
you
is, yeah.
routinely do innominate angiograms.
Yeah, no, actually it's a, okay, yeah. Yeah, I think we are okay.
That appears to
You
line up
can see that
perfectly.
the innominate fenestration is lined under that. So I'm beginning my deployment. I don't start my pacing at this point of time. I wait for the first covered stent to start deploying, then I'll start pacing. So that reduces the time of ischemia. Just acquire this. Okay, so the graft is beginning to deploy. Can you start pacing now? Pacing on at 180? Okay. So I'm going to do a rapid release. Stop pacing. All right, now let's look at the three pressures. On the screen here, can we show this pressure to the audience? Yeah, I think you can see it.
can see it.
There is a blue, which is the left carotid, and the red is left subclavian. And the anesthetist has the innominate, which is reading 138. So I know that all three fenestrations are flowing, and there is adequate cerebral perfusion. So now we'll release the top cap of that, yeah. All right, so the top cap is released, and now we will recapture the nose cone. All right, so now we'll just hold the wire there. I'm going to take the device out. Sometimes this top cap snags the graft, but that's not the case today. So the device is coming out, and I'm going to remove it altogether and put an 18 French sheath here. Although this device is 24 French, 18 French sheath is enough to plug the hole, because the artery is a bit elastic, and I find that 20F sheaths, the outer diameter is almost 24 French, and that tends to, traumatize the iliac arteries. So I'm putting an 18 French sheath in, and so we have deployed the device and all the 3 fenestrations seem to be reasonably aligned. So now we are going to cannulate them one by one. Actually only 2 of them. We only cannulate the left carotid and the left subclave, and the innominate I am just going to leave alone because I have got adequate seal beyond the innominate. The idea of starting in the ascending is that the ascending is straighter than the arch, and the graft has more stability when you start in the ascending, and the inner curve is very nicely covered. The fenestrations are all on the outer curve. So very often you get this bird beaking graft with a inner curve type 1 endo leak, which we don't get because we are starting in the ascending aorta. So now I am going to try and cannulate the left left carotid. We don't need a catheter, I just want the wire. So for this, I will probably disappear from the view because I am going to the head end and drop the wire in. I need that micropuncture introducer. How do I get there? This way, no? Then you remove that pulse oximetry for time being. Let me get through. Let me go, yeah. You can remove that pressure line also, it's okay. Yeah, that's good. Okay, now reduce the LAO. We don't need this LAO anymore. We can work in almost AP view. Give me the wire. I'm going to stop this infusion. Take that. Okay, wire is coming out. Just press the fluoro. I need to see. All right, so I'm dropping a wire in from the left carotid dilator, and I think I crossed it. See the wire? Can you see the wire on the fluoro?
Yeah.
So, you know, the fenestration is absolutely right because the wire just fell through. I didn't have to do any manipulation whatsoever. So this system which we use, which we have devised actually, has not been reported before, but it's so precise that we generally spend less than a minute crossing the fenestrations. All right, so
How do you
now
confirm that
I've
you're
got this wire through the left carotid.
How do you confirm that you're not
Yeah,
behind
so
the
we're
graft?
going to now put a, yeah, there are several ways. One is you pull the wire up and you rotate it. And you can see I'm rotating it and it's freely moving. The tip is just spinning around. That can't happen if I was under the graft here because the graft would be opposed to the wall. Second is now I'm going to go in with a snare over the Lundquist wire, a snare on the Lundquist wire, and I'm going to catch hold of the tip of this wire and exteriorize it from the femoral artery. So I'll have a through and through loop. So if that loop moves directly from the left carotid fenestration to the descending aorta, I know I'm not under the graft. Whereas if I was under the graft and I caught the wire in the ascending aorta below the graft, then it would loop around the end of the graft, the top end of the graft before coming out. So my colleague Sujit is bringing in a 6F snare over the Lundquist wire. That's the snare catheter, after which the wire will be removed and the snare loop will be introduced. Go all the way to the ascending. What are you doing? Catheter alone, please. Don't drop the wire, just be careful. One important thing while working on such cases, we have these long wires going down the table. I always try to clip them at 1 or 2 points because before you know it, there'll be one end on the floor. So it's something which we've learned the hard way. So, okay, so now Sujit's got his catheter up there. He's going to remove the Lindquist wire, take it out and bring the snare, please. Just bring the snare. You can use the blue tip, give the blue tip. No, from the other end. No, take that off, it's okay. Oh, okay, that's also a good way of doing it. Yeah, all right. So we have another 14 minutes, so we'll try to show you as much as possible. We don't have too much left. We just basically have to just deploy 2 stents in the left carotid, left subclavian. So I'm just trying to drop the wire through the snare. Yeah. So you can see that Sujit has caught the wire and he is now exteriorizing it, and you can see that the wire is taking the short loop through the graft. It's not coming around the top end of the graft. So it is definitely gone through the fenestration.
Very nice demonstration. Yeah.
All right, so he's now, give me a clip please. So he's going to pull the wire till he can get as much of it on the other end. And I'm just going to put a clip at this end. Okay, give me a flush please. And then now we're going to work from the lower end. Get the Ansel sheet 7. Okay, I'm going back there.
So George, why not go through the graft? Was it more difficult going through the graft and through the fenestration and to the carotid?
You mean reverse, go down, go
Right.
from below up.
Right. Retrograde.
No, I like, there is an advantage in what we are doing. That is that the angle from the left carotid into the graft is more favorable to cross. When you come from below, you got to do quite a sharp bend to get into the carotid. This one just fell through. I didn't have to do anything. The second thing is, now I've got an exteriorized wire which gives me control on both ends, and so I have a very good stability. And you will see now I'm bringing a 7 French sheath. This is a 7 French 70 centimeter Ansel sheath, and it's going up the carotid. And go a little LAO please. So it's gone up the carotid, and we are going to work on the same wire. It's basically a soft Teramo wire, but because I've got control at both ends, I don't need to change it to a stiff wire. Aspirate flush, silene 832. So I'm going to deploy a covered stent. It's called the silene. Can somebody show the cover to them? It's made by Insight to Technologies. Show the cover, please. Can you show the cover? Not this, that cover. Give the stent to us.
We are with
Give
you for
the
another
stent to
5
us.
minutes, George. And so please.
Can you show this cover, please? Yeah, okay. So we'll just deploy one stent for you, maybe. Then there's only the subclavian stent to deploy, and then the case is done. So I'll just show you this one, and even if that works, I mean, that should be enough to give you an idea of what the next one is. Basically, we come from the left radial and drop a wire down and snare it out just like this and deploy one more stent.
Sure.
So we are almost done. Maybe I won't have the completion angiogram to show you, but the important part is over.
Yeah.
Okay, so the saline stent is being loaded on the wire, and it's coming in. It's a 8 mm diameter, 32 millimeter length covered stent. Okay, so you can see it here. So it's going through the 7 French sheath, and I'm going to position it so that about a little bit is outside the graft. Now the dilator is obstructing the passage of the stent into the carotid artery. So I'm pulling the dilator back. Yeah, so now the stent is adequately into the artery. All right, so I'm pulling the sheath back now to expose the stent. Yeah, so we are ready to deploy. Now you can see that the angle is towards the descending, but we'll correct that as we deploy. Pull back? Yeah. Okay. All right, so we are ready to deploy. I pull the sheath back and expose the stent. Okay, Sujit, please deploy. So we're going to deploy it at 8 atmospheres. So at this stage, I push the shaft of the balloon, and you can see now I've oriented it towards the ascending aorta. Okay, deflate. Epic 940. Now we're going to take the balloon back into the stent, and then we will inflate it at a little higher pressure. Yeah, okay, it came back into the sheath. Just do one more at a little higher pressure, say 12. All right, this is at 12 atmospheres. Okay, deflate. And the next thing I'll do is to line this stent with a self-expanding bare metal stent. Let it deflate properly. Okay, so the balloon is coming out. I'm taking the sheath a little forward. So the bare metal stent we're going to use is called the Epic, and it's made by Boston Scientific. And open it please, 940. So the idea of this is it gives additional radial strength. Second is it's slightly longer than this stent. So the distal end of this stent, even if I produced an edge dissection, this will cover that, and it will also smoothen out any angulation that may be there at the distal end of the stent, because this is a rigid balloon expandable covered stent, so it sometimes produces an angulation. Okay, so the wire is a little short. Okay, we've got it. We're working on a 260 centimeter wire, so sometimes it's a bit short, but we do manage to work with it. One mag, please. All right, so the stent is going in, so I'll go a little higher up. Oh shit. I've actually pushed that stent in, the covered stent. So I need to put another covered stent. Can you get another silene, please? So the end of this stent actually hit the silene and pushed it up. No, give 932. See, actually the carotid is more than 8, and I've only used an 8 mm stent, so it was not very a snug fit. So when I was trying to bring that bare metal stent in, it pushed the covered stent up. So that makes it necessary to deploy one more covered stent, because the covered stent has to project into the aorta. That's the important thing. So that's a problem. Now we're going to have to put the second covered stent.
So your plan is to put...
Now if I put the second covered stent, then I may not need the other stent, because now I've got double covered stent, so the radial strength is good, but that radial strength is not at the fenestration. It will be higher up, so it may not work. I may still need to put that bare metal stent. All right, so here comes the same silene again, but this time I've gone a millimeter bigger, and I will have to project into the aorta again like before, but it's pushing that stent up. I think that we need to just feed the wire in a bit. Okay. Yeah, all right. Okay, go. Yeah. Yeah. Okay, now you can go say 15 or something. Okay, so this is we've gone to 15 atmospheres, so we can see that the fenestration is absolutely, filled by this balloon. So there's no gap around it, and we have probably good enough seal. So I'm going to do an angiogram and then decide whether we need to put that bare metal stent in. Okay, so it is deflated. Yeah. So we shouldn't create the same problem again. So if I put the bare metal in, I have to be extremely careful that I don't push this one up again. Otherwise, we'll do a sheathogram. I've got just 2 minutes more, so we may not be able to show you everything here.
Dr. Joseph, I think we've extended it by a few minutes, so
But-
if we get cut off, we extend it by 5 minutes. So
Oh, okay. All right. All right, great. Actually, you know what, I'll increase this bare to 9 mm. This is 9, no? Should we put a 1040 or 1060 dear? Epic 1060. I'm going a little longer because there are 2 stents overlapping and the length may be more than 40. And the second stent should be a little bigger than the first 2 stents because this is self-expanding. So if it has to be snug, it should be a millimeter bigger at least. All right, so yeah, it's okay, just squirt some dye, that's all. Yeah, okay. It looks good. Is that a 1060? Okay, then maybe 1040 is fine. Okay, they are trying to get us the right size of stent. Yeah, they've got a 1060. So I have chosen a 1060 now because the length may be more than 40. So the lengths come in multiples of 20. So I have stepped up the diameter by 1 millimeter and the length by 2 centimeters. So they're getting that ready. And this time the challenge is to get that in without pushing on the silene stent which is already there.
it seems difficult because the angle is pushing you right into that stent as you go up. Is there any other tricks that you can do at this point to try and reduce that risk?
Yes, I could do, I could buckle the wire down the ascending aorta a little bit so that it enters the silene stents more coaxially. Now when I'm coming from the descending aorta, it's going and hitting the side of the silene stent. That's what happened the first time.
I think pushing the wire will help you.
So will you push from the carotid?
Yeah,
You can push
we'll
from the
see.
carotid down to- push it from the carotid down to-
The wire is externalized, so it's not going up the carotid, it's just coming out of that dilator. Okay, so I'll do this very slowly. No, it's not come yet. Still got some friction there. Oh, it's hitting the dilator. Yeah, show a little up. All right, so we are in. Yeah, so we need to project a little more than the existing stent. So I think that's okay. Okay, so Sujit will now deploy the EPIC. Basically, he has to just roll the wheel slowly. Yeah, keep going. Yeah, I'm keeping a traction on it so that it doesn't slide up. Yeah, okay. Yeah, keep going. All right, so we have deployed it, and yeah, you can see it's slightly flared out. So take the system out. So we are done with the left carotid, and we have taken our stent well past the covered stents. The epic has gone well past. It's maybe a centimeter more. You can see a slight angulation there, so that's good to cover with a bare metal stent. So this is done. So now we're going to move on to the left subclavian and do exactly the same thing.
George, I think we're running out of
So
time.
whenever you
Yeah, I think with that,
Okay.
actually, you have shown an excellent demonstration of how to do this complex procedure.
Thank you,
we-
you have done the wonderful job.
Yeah, we congratulate you. And any comments, Sushil, last comment?
No, it's an excellent demonstration. It's a very thoughtful procedure, a lot of planning, and you really helped demonstrate that very well. How much effort? It's not something you can just go ahead and do. You have to think and plan and patient-specific anatomy because you're trying to use existing devices that aren't designed for this application. So very nice example, very nice demonstration. Congratulations. Thank you.
Thank you.
thank you, thank you. Bye then.